Myself, Dr. Devodarshi from Bhubaneswar. I'll be speaking on the bipolar TURP. Most of the time have a lots of nomenclature like bipolar, plasma, kinetic, or saline TURP. It's all the same. Bipolar means both the electrodes of the active and passive on the same place, and the current doesn't pass off through the patient body plate. Yes, it is the medium is saline. That's the reason it is called a saline TURP. And plasma, because plasma is one of the four fundamental states of matter created by applying energy to this gas. When the energy passes to the gas, it's converted into a plasma, and the conductivity of the plasma allows energy to cross at a very lower level. That is the reason it maintains a very cool temperature in the point where it is being resected, and the surrounding temperature is very less. That's the reason the less thermal spray, and it acts mostly most of the time when we use either laser or monopolar. It is a mostly a thermal driven process to cut or to remove the tissue. But here it generally has a constant field to remove this. By this, it causes minimal thermal damage to the surrounding soft tissue. The plasma kinetic has got a very nice yellow cloud at the tip of the electrode. It's all because of the sodium inside the medium. Coming to the history, 1910 only, the Bayer was the first to perform the endoscopic bladder resection, which is now at the gold standard for diagnosing, preliminary diagnosis of a bladder tumor to take further treatment. And Wang and colleagues, they are the first to report the bipolar TURBT. Saline, why we use saline for bipolar resection? Saline is a osmotic and non-hemolytic, whereas water is hemolytic, glycine, and water is hypotonic. So the concept of saline came for long duration procedure. So what is the utility for these short procedures like TURBT? When we take up a long, larger prostates, more than 150, 180 gram prostate, more maybe 200 gram prostate, then may use this because of this no is very safe, and there is no dilution of hyponatremia at the end of the procedure. But yes, this is the visibility compared to water is almost all the same. The people, what actually Dr. Ramesh has already told us why this is as far as the monopolar and bipolar is concerned, there is no significant difference between the efficacy, the bleeding, the operator jerk, but the people claim that the bipolar is bipolar is very fast cutting because of the shorter circuits. It's less travel to the metal because of the receptoscope. So there is low chance of stricture because the impedance is very less, and the surface area for the cutting, for the transmission of the electricity is very high. There is less chance of TUR syndrome. There is operator jerk is very less, people they claim, and obviously the quality of the sample, histopathological sample given to the pathologist will be very less. But to me, bipolar, what it does actually, the vision. From the start of the procedure till the end of the procedure, because there is no charring at all, you have the same kind of vision at the start and at the end. And next is, when the mass is very nearer to ureteric orifices, most of the people, they put the guide wire, they do the scopy, or they do the RGP at the end of the procedure and stent the patient. But in bipolar, if you have a very thin loop, then probably you are not going to do all these things, and rather you can confidently go ahead with resecting the tumors when it is close to ureteric orifices. At the same time, when Dr. Ramesh has shown an enucleation of the tumor, en mass, en block, I will also show the same thing, but you see the difference. There is no charring at all, and there is no tissue depth burning. That is the region, the vision is very clear, and it comes as en mass. At the same time, the most important is kind of a KTP laser. It is the vaporization. we can do the vaporization with this bipolar system with a button electrode. The same is like the monopolar or the bipolar. I have to put this patient on general anesthesia or an NOR block. Then I have to inspect the bladder. I usually use Olympus ESG 400, and the settings I always keep at 200 watt for cutting and 100 watt for coagulation. Use a 26 French Olympus continuous receptoscope, passive working element. Always I have thus in mind like half-filled bladder. The tumor I resect from top to the stalk, as every other surgeon does it, and they all the same submit to stalk, and you have to take the sample of the biopsy of the underlying bladder muscle, detrusor muscle, in this separate container. And if you are planning for a new bladder, then you have to take for a bladder neck biopsy. Then you have to put the patient 20 French Polish catheter, and for irrigation 6 to 8 hours. This is a video where it is a 3.5 centimeter tumor. It is very close to the VUSA. You see this en masse enucleation of this, where
Dr. Rath, could you close your own video? The surgical video will run smoother.
Yes, sir. So this where you see, and it's being lifted up without any kind of charring underneath. That is the reason the picture remains clear, and whatever the amount of bleeder that comes underway, it gets coagulated very nicely. And at the end of the procedure, but the only thing with this enucleation is, if you don't have a morcellator, then you have to resect it once again, just like a conventional TURBT. It is very just like a conventional TURBT. This is one more case where the patient had a bladder stone. Patient came with a bladder stone, but when I inspected the bladder, then I found a mass around the ureteric orifices. The right ureteric orifices could not be visualized. So that is the reason we went ahead with a resection of the mass. When we see, but after resecting 2 to 3 slices, we are able to see the nice ureteric orifice, very patulous right ureteric orifice, right side. This is why the bipolar, we can do the resection very confidently without harming the ureteric orifices, even if it is very nearby and close to the orifice. This is, you see this very patulous wide ureteric orifice. And this one case, it was a very large bladder tumor hanging from that dome of the bladder, where I had a very difficulty in mapping out where to resect, how to resect. After getting 2 to 3 slices, it bled so heavily, I even could not reach up to the point of bleeder. That's the reason I took out my button electrode, which coagulated the same point very easily within a fraction of a second. Then I vaporized the whole of the almost 50% of the mass in no time, because it's very fast. It eats away, basically it eats away the mass, and without any drop of bleeding. After that, when I was very confident to get the maneuver to resect the rest of the tumor, I went ahead and resect the rest of the tumor. So this is how the bipolar has got all the facilities. We can resect, you can enucleate, on top of it, you can vaporize the bladder tumor, even if at all it is not easy to approach. not easy even to control the bleeding, then vaporization is one of the options you have left with you for resection. Thank you very much.